I'd like to introduce Ken Burns this morning, who will introduce our speaker and our program. Thank you.
Okay, thank you, Julie. Our speaker this morning is Dr. Yuri Orlova, who's an assistant professor in the Department of Neurology. And she's going to talk about a medical problem that is, forgive the pun, a headache to many of us, namely migraine. And Dr. Orlova was educated in Siberia. I went through Siberia State Medical School and got her original training in neurology there. She then came to the United States, where she finished her neurology residency at Rutgers in New Jersey, and then moved to Boston, to Harvard, to do a fellowship in headache medicine. And once she became adept, she looked around to see where headache medicine would be useful and decided that the University of Florida was a good location for a variety of reasons. I'm sure that the sunshine had nothing to do with her choice after her background. But in any event, she came here in 2017 and she teaches and she is a clinician, and she's going to talk to us today about our current understanding of migraine headaches and the misconceptions and advancement in treatment, including novel therapies, which are both pharmacological and non-pharmacologic. And I think if you think back to last summer and the course we had on holistic medicine, you can imagine what some of the things may be. In any event, at this point, I'd like to welcome Dr. Orlova. Good morning.
Good morning, everyone, and thank you so much for such a wonderful introduction. And it's a great honor for me to speak to you, and it's also challenging. You're a very new audience for me, and I hope that at the end of the talk, I will be able to explain how, as a physician, as clinician, see this problem, and for you, as non-medical professional, I believe that this is a very, very important topic, because sometimes we speak like in different languages, and there's a lot of misunderstanding and a lot of misconception. And I hope that you'll be able to at least have some common ground at the end of the day. I would like to try to advance my slide. Let me find the trick here. Here you go. So I would like to start with a few terms. The language that we use describing headache disorder is very important because words we use may have completely different meaning. First, if we talk about headache, it can be describing a descriptive term for pain in any location of the head, but it can also mean a thing or person that causes worry or trouble. That's why the Coalition of Headache and Migraine Patients recommended using more specific term headache disorders that might describe a number of different medical conditions. In fact, there are more than 100 known headache disorders, and they can be broadly divided in two groups: primary headache disorders, which include migraine, tension type headache, cluster headache, and some other rare conditions. Those are diseases in their own right. They know the symptoms of other conditions, and they have very specific treatment, both acute and preventive medication, non-pharmacological therapies. And the second group is the secondary headache disorders, where headache is caused by other condition, and main treatment would be gone after the cause. For example, headache is a very common symptom of infection, such as flu, and a COVID infection as well, or a symptom of head trauma after the fall. Finally, migraine is, oops, sorry, should have moved it. Migraine is even more specific medical term, which describes a chronic medical condition with recurrent attacks of severe headache and other associated symptoms. It's also most common primary headache disorders that people go to the doctor for. And it's one of the top 10 reasons why people go to emergency room. Migraine attack in medical terms is severe headache associated with other features characteristic for migraine disorder, and we're going to talk about them. Again, we describe, so we talk about headache as in general term, headache disorders and a migraine. So the word migraine comes from French, which is itself derived from ancient Greek, which is called hemicrania, or pain involving just one side of the cranium. It also means a type of a flatfish or sole, and actually this is used as a mascot in headache medicine. And you can think it as a kind of insider's joke, but this is a fish that they put in a diploma on some of the awards and advancement in the headache medicine. But it also means that it's a very old term that was used for centuries, but there are also other descriptive terms, such as sick headache, bilious headaches, and blind headaches. And that's emphasized that there are other typical symptoms with this headache. And again, the migraine is not just a headache, there are other symptoms coming with it. One of our larger textbooks of headache medicine defined migraine as a very common neurological disorder characterized by recurrent attacks of severe headache, autonomic nervous system dysfunction, and in some patients by aura. I would like to bring to your attention the fact that migraine is defined as a medical and more specifically neurological condition, and with various signs in addition to recurrent severe headache. This is a very important distinction because it goes beyond just describing the symptom. And it also acknowledges that there are different types of migraine with and without aura among other types. I would like to briefly overview the history of migraine studies. Headache has troubled humankind for centuries, actually for thousands of years. And our understanding of migraine has changed dramatically over the centuries. From historical perspective, it's very interesting to see how our understanding evolved over thousands of years. And I include here just a few landmarks. The earliest mentioning of headache can be found in Mesopotamia, which is the modern-day Iraq, dating 4,000 years BC. And it indicated the beliefs that a headache is caused by evil spirits. And this concept dominated for centuries in medicine and believed to be justification for such a treatment that we might consider barbaric at this time as bloodletting or even skull trepanation. But in the first century, Aretius of Cappadocia first distinguished migraine from general headache, and he noted also periodic and affecting one side of the head, and also associated symptoms such as nausea. So that's where the shaping of this condition as a distinctive type of headache started. Another famous ancient doctor, Galen, well, a little bit later, defined different types of headache as cephalalgia, cephalae, and hemicrania as a separate headache types. Notably, this terminology dominated for almost 2,000 of years, and some of this term we still use in our classification. Our modern understanding of migraine as neurobiological disease was shaped by a few physicians that I thought that I should include in this slide. And in 19th century, Hubert Airy depicted as a superb imaging of his own vision aura, which is a transient vision symptoms he described as a beautiful colored lines, zigzag lines at the periphery of his vision. And his picture is still used to teach medical students. They are so beautifully made. And this vision disturbance usually affect about 30% of the people with migraine, and they call this typical vision aura. And this is a distinctive type of a migraine with aura. In 20th century, it was Harold Wolff who explained head pain due to dilation of the vessels in the brain lining. The concept is now called vascular theory of the migraine. And this theory did dominate the headache medicine through the entire 20th century. And the theory proposed that migraine develops in two stages. The first is a vasospasm, or the narrowing of the vessel, which explain the neurological symptoms at the onset of the attack, followed by compensatory dilatation or opening the vessels, and which is triggering the pain. However, later studies showed that vasodilation or openings of vessels does not correlate necessarily with the generation of the pain. And it also became clear that the medication that used to abort migraine attack do not work by changing diameter. They do not open or close the vessels. And we're going to talk about this a little bit later. In mid-20th century, another physician, Carl Leschly, observed his own aura and suggested that it comes actually from a wave of intense excitation over neurons, and that traveling across the occipital, or the back part of the brain responsible for our vision. And this wave is followed by complete inhibition of activity of the brain with gradual recovery. And this phenomenon, known as a cortical spreading depression, and this concept formed the neuronal theory of migraine, another theory. And around the same time, Aristides Leao discovered cortical spreading depression. He showed that it does exist in experiment, which further solidified our understanding of the migraine as a brain disorder, not a vascular disorder. Going back to the modern day, how common is migraine? Well, it's actually one of the most common and one of the most disabling conditions. Migraine affects 1 of 6 adults. It's more common in women than in men, and 1 out of 5 women is affected by migraine, and 1 out of 10 men affected by migraine as well. Interestingly, the boys start having migraine earlier than the girls, and an average age when the boys develop migraine is 5 to 7 to 8. But in the teenage years, the girls catch up and then surpass the boys. So that's how migraine affect more women than men. But again, it does not mean that men do not suffer. As 10% of the men, it's pretty high percentage of the men that are affected with a migraine. In the world, migraine ranked as the 3rd most common disorder. And it's also the 3rd highest cause of years lived with disability in both male and female under the age of 50 years. I wanted to take a look at this graph that show data from CDC in 2002. So in that year, 1% of people had rheumatoid arthritis, 5% have had asthma, and 6 diabetes, 7 osteoarthritis, all very common condition. But migraine affected 12%, which is more than asthma and diabetes combined, which is a lot of people with migraine. And years lived with disability is another term that is, I would like to take some time to explain what it means. If you consider this a migraine as lifelong disease that people start experiencing since they were children, and it may last through their entire life. And if you count all these days that individuals spent in bed, missing all the social activity, missing work, missing the leisure activity, missing family time, and all adds up, and that's how the migraine become the top 3 leading disabling disorders. It's not a stroke, it's not dementia, it's not asthma, this is migraine. And perhaps the fact that migraine is so common that there's a general perception of the public that it's a trivial disease, but it's nothing but, and it's a very severe condition and very disabling condition. What are the symptoms of the migraine? Well, it's a recurrent headache attack lasting 4 to 72 hours, meaning that it's not the pain that will go away by itself in half an hour. It's hours or days ordeal that people going through. It usually involves one side of the head. It's usually throbbing and pulsating. And that's what actually sparked this vascular theory, that it's throbbing. You can hear the pulsation. It must be related to the vessel. Pain is moderate to severe. So migraine is not a mild condition. It's either moderate or it's severe condition. And it's also sometimes people, especially employers, don't realize when their employee missing the days. It is, again, severe condition. But it does get worse with routine daily activity. And routine daily activity is just like standing, walking, just keep your eyes open, just talk to somebody. And associated symptoms are also part of disability: nausea, sensitivity to light, sensitivity to sound and odors, and vomiting. There is a ID migraine screener that we use in clinical practice when we don't have enough much time. So this ID screener was developed to briefly diagnose a migraine when you have time only to ask 3 questions. So during last 3 months, did you have a following with your headache? You felt nauseated or sick to your stomach? Life was bothering you more when you don't have headache, and your headache limited your ability to work, study, or do whatever you need to do. So if you answered yes to 2 of these questions, then you have a migraine. And you may try this if somebody has a headache condition. I would like to go through this slide that it seems very busy, but we're gonna go through each stage, each phase of this, because a migraine is a cyclic disorder with recurrent attacks. And each individual attack goes through the different phases that involve different parts of the brain, and it has different symptoms. One of the reasons why migraine is more than just a headache. About 75% of people with a migraine can experience symptoms that we call premonitory, before the headache even started. They may feel fatigue, sensitive to light, they may have certain food cravings, including chocolate or salty food. They may feel yawning, may have a fluid retention and a heightened perception. This phase is linked to hypothalamus as a deep structure in the brain that is responsible for waking up or sleeping or feeding, and which can explain why lack of sleep or skipping the meals can actually trigger migraine attacks. And interestingly enough, this is a phase actually sparked a lot of controversy a few years ago when the study showed that when they tracked all the triggers in the people who say, yes, I have a trigger, let's say the chocolates trigger my headache, and they found that it's highly overrated. It's not the chocolates that trigger the headache most of the time. It's a headache trigger unusual cravings. So as an individual makes this connection, well, I had a chocolate and then I have a headache, it must be chocolate that's causing it. So chocolate is being rehabilitated at this point. So so if you have a migraine and a chocolate is not specific trigger for you, that's okay. You can probably enjoy it and don't trigger additional attack, because the connection is not that straightforward, and there may be cause and consequence may actually change the sides. And about 30% of people experience aura, is the next phase. transient neurological symptoms, which is most commonly visual and less frequently come as a sensation of the pins and needles, numbness, weakness on one side, or confusion. Typical aura lasts about 5 minutes to 1 hour and usually starts before headache phase. So there's no headache still in this aura. Although it can happen in some individual during headache phase or may even come without headache at all. It's more, it even has this specific terms that we use, late life migraine accompaniment, when people experience typical auras, but no migraine with it. And it's linked, this phase is linked to abnormal electrical activity of the brain, which starts at the back of the brain. And it travels forward and slowly spreads, causing visual disturbances and other symptoms associated with migraine aura. So let's take a closer look at this phenomena, which is schematic representation of cortical spread in depression, which starts on one side of the back of the brain, which is responsible for our vision, and travel forwards. You see the red line here. As it travels through the different parts of the brain, it causes neurological symptoms. Because the back of the brain is responsible for vision, most common symptoms of migraine aura is vision aura. But in some cases, it involves areas responsible for sensation of the skin, right here. So individual may have pins and needles, numbness on that side of the body. And as it travels forward, this is the area that's responsible for controlling our movement. So some people may have weakness on one side of the body as a part of the migraine aura. And this wave of abnormal brain activity triggers leakage of a lot of biologically active molecules. It causes vasodilation and expansion of the vessel. And this, in turn, irritates, aggravates the trigeminal nerve ending that are located in the brain lining and around the vessels, which is heralding the headache phase. As this wave eventually dissipates between 5 to 60 minutes, so this is the time frame, it starts here and it finished right there, it leaves behind the area of exhausted brain cells with reduced blood flow, which gradually recover, and that's why this phenomenon called depression. And I want to bring you to your attention that in our current understanding, the migraine is not exactly vascular disease. And dilatation or the opening of the vessel is not a cause of the pain, but rather consequences of all this cascade of electrical and chemicals changes that going on during migraine attack. Another point here is that the number of biologically active molecules important in migraine, such as serotonin, dopamine, epinephrine, and most recently discovered CGRP, all are target for new migraine-specific medication. And most of the treatments that we use currently to treat individual attack are targeting all those chemicals that are leaking during this phase. That's how the typical vision aura looks like. There's both combination of so-called positive symptoms, which you see the colored, beautiful rainbow colors, the periphery of the vision here and there, and the blurry vision, or we call it negative symptoms, which represents a combination of abnormal excitement of the cells and exhaustion of the brain cells as these waves travel through the different parts of the brain. Next phase is actual pain. It typically lasts from 4 hours to 3 days. And in pain phase, now active nerve endings that were just aggravated and agitated brings information about all this electrical and chemical disturbance to the brain, where it's being transformed to the experience of the pain as a human experience. And at this phase, many brain structures are involved and leading to the multiple symptoms that accompany migraine. That's how the migraine attack, the pain is unpleasant sensation, which is emotional component. That's where the nausea is generated, sensitivity to light, sensitivity to sound, and even vomiting. All of the symptoms of irritation of the brain. And as I already mentioned, most of our acute medication to treat migraine attack works at this phase. And they work in other, by blocking the release of painful molecules or tuning down the transmission of a painful stimuli. Migraine is traditionally described as a pain on one side of the head, but it's not always the case. I want you to take a look at this picture. And on the left hand, you see the migraine headache attacks that happen on one side, typical unilateral. And on the right hand side, the plate B, you can see headache, migraine, specifically migraine attack that involves both sides of the head. In red, you see the pain and a tenderness, associated tenderness in green. And you can see how easily migraine can be mistaken for sinus problem. This location is right here, or the neck pain, or temporal mandibular joint dysfunction. So in migraine, I want to emphasize that it's not the location of the pain that defines a migraine attack. It's the other symptoms that come with the migraine come with the entourage. It's associated nausea, sensitivity to light and sound. And many people feel pain in the neck and the base of the skull. And if this pain comes with other associated features, it's a migraine. It's not degenerative disc disease. So that's and one of the clinical implication of this slides. What also many people don't realize that after resolution of a headache, up to 80% of the people with migraine have symptoms such as fatigue, lack of appetite, excessive urination. We call those symptoms a migraine hangover or post-drome. It can last up to a couple of days. And it's very poorly understood, and we don't have specific treatment for that. But when you think about migraine as a cascade of the event, it makes sense that not everybody can immediately recover from all of this chemical and electrical events. And it takes some time when all these substances and chemicals being cleaned up and neurons being recharged. Interestingly, this is what happened naturally in sleep. And maybe that's why sleep plays a particularly healing role in migraine attacks. So what about interictal phase or the time between the headache attack? What makes a person with a migraine susceptible to head pain? Our current understanding of migraine as a disease of increased sensitivity to different triggers in people with genetic susceptibility. There's a common saying in medicine that genes load the gun and environment pulls the trigger, which is a good analogy here in migraine as well. And the role of different triggers is recognized for centuries in migraine, but how exactly these triggers provoke the migraine attack is not completely understood, and there's still a lot of debates going on in this matter. But we know that there is a number of factors that predispose an individual to migraine. They're very variable. Genetic does have a role as a predisposing factor, and many people with a migraine have many relatives with migraine as well. Migraine does run in families. There's a few specific genes are known that causing certain rare migraine condition called familial hemiplegic migraine. But it is estimated that genetic has only 40 to 60% impact in migraine. That means that when they studied the genetically identical twins, only half of the pair of twins both had a migraine. So they equally genetic, so genetic had 100% in their particular cases. But the other half of the twins pair only one had a migraine and another doesn't. So there are other factors, that is, genes play their important role, and those factors can be both external and internal. And external factors most widely reported as triggers alcohol, food additives, environmental pollutants, chemical exposure, and drugs. We know that introducing in infusion of certain chemicals such as CGRP proteins that we already mentioned and prostaglandin can trigger migraine attacks. So you bring some chemicals from outside, you introduce it to the body, and you will have a migraine attack. That's how the newest migraine medications were discovered, targeting CGRP. And we're going to talk about those medications as well. But there's also internal factors such as stress or anxiety, hormonal changes, hunger, physical exertion, increased sensitivity to light and odors. And I'd like to think about triggers as having cumulative effect in a person who has a low threshold to migraine attack. Not everybody who has genetic predisposition will have a migraine. So does not everybody who has a migraine necessarily have to have a relative with migraine. But now the implication here is that simply avoiding a specific trigger is very rarely effective in migraine treatment and cannot be practical. For example, if you think that the weather is a big trigger for your migraine, what are you going to do? It's very tempting to move somewhere else, but I'll tell you that migraine affect people from Alaska to all the south of the Florida, from east to west, from north to south. So there is no place on earth where it's geographically so perfect that you will never have a migraine. So it's not very practical, but if you think that the adjustment of the light in your office and you have a healthy dietary habits, including less food additives, having regular balanced meal and regular hours to sleep, those can all be very helpful in modification of your threshold to pain. And that brings us to importance of a lifestyle modification such as sleep hygiene and nutrition. I want to spend some time talking about this. So what sleep hygiene and routine means? Well, schedule consistent bedtimes that allows 8 hours time in bed. In young kids who also have a migraine, their sleep needs are higher. They may need up to 10, maybe even 12 hours to sleep. But as we mature, 8 hours seem to be physiologically sufficient. Eliminate TV, reading, and music in bed. Use visualization techniques to shorten time to sleep onset. There are many can be found on YouTube. I just put one link here as an example. Move dinner to more than 4 hours before bedtime, so you don't go to bed fully stuffed and feeling overwhelmed by food. Limit fluids within 2 hours of bedtime, so you don't have you have less urge to get up in the middle of the night to go to the bathroom. And discontinue naps. What the second part, the nutrition, is traditionally considered very important in migraine management, but there is no unique proven diet for migraine, unfortunately. And we think that the food triggers are overestimated. Food triggers are not universal. And some patients are very sensitive to specific triggers, and others keep looking for triggers and never found. What is underestimated, unfortunately, is skipping the meals, especially breakfast. So having regular meals is extremely important in migraine management. Staying hydrated is very critical. Drink water, not coffee or soda. Those are actually can dehydrate you more. And how much to drink? Well, there is one very simple vision clue. If you go to the bathroom and take a look at the color of your urine, it should be nearly colorless and very, very light colored. because our needs for hydration depend on what we're doing, depend on what the temperature is outside today, and what else, what's many factors. So today you may need 4 glasses of water, tomorrow you may need 8 glasses of water. Caffeine is very important. Many people with a migraine have very complex relationship with caffeine, because a little bit of caffeine can be very helpful in treating migraine, especially if it's not severe and it just started. But excessive caffeine intake is linked to persistence of the headache. And be aware of other sources of caffeine than just coffee. I brought this this picture here just to get a comparison. So the large coffee cup from Starbucks, say 300 milligram, and a can of Coke. So 1 cup of coffee from Starbucks has as much caffeine as 9 colas. When you think about it, the numbers are as really frightening, at least for me. So if you brew your own coffee, you can probably regulate it and make it not as strong. Mug of tea does have caffeine as well, especially if it's black tea. Green tea does have a caffeine as well. So you might want to know those numbers if you have this complex relationship with caffeine. So if you enjoy your coffee, well, brew your own, first of all. And second, you can swap half of coffee with decaffeinated. So you will enjoy a little bit of caffeine. You'll enjoy your daily routine. You'll enjoy the flavor, but you're not going to be overusing caffeine. That does have pharmacological effect on your body. And it causes increased urination, increased acidity of your stomach. So there are many pharmacological effects of caffeine. Let's move on to the medical treatment of a migraine. We traditionally describe this treatment as a preventive treatment. And we consider this when person has between once a week to twice a week headache days and months, on average 4 to 10 headache days a month. The goal of preventive treatment is reduce the headache frequency and intensity of the pain, not to treat individual attack. And it can also help to improve an effect from acute treatment of individual attack when they happen. And most of the preventive treatment until recently were daily medication from different class of drugs. And when we treat individual attack, we call it acute treatment. Treat migraine early at the onset of attack, but not too often to prevent rebound headache. Medication overuse headache is a big problem in migraine, and it's unique to people who suffer from primary headache disorders. Basically, medication overuse headache is a complication of a migraine that is not well treated, is not well prevented, and it's come from excessive use of combination medications such as Excedrin. This is over-the-counter medication, or Fioricet, which is a medication that is 60 years old, but still in clinical practice, many physicians use it as a first line, which I, as a headache specialist, I don't understand why, but this is the current practice. Opioids, such as Percocet and Norco, also commonly prescribed, especially in emergency room, and they have a very high risk of rebound headaches, and they're not good migraine medicine. There are a lot of therapeutic options that are much more effective, much more specific to the migraine. And that's why I thought I'm going to bring this table to you. So I can explain that we have a lot of options that are migraine-specific therapy, which target all those molecules that lead during migraine head phase that we described them already. And the older medications, non-selective serotonin, dopamine agonist, ergot derivatives, you might know about Keff-ergot, medication ergotamine, dihydroergotamine, the migranal, they all belong to this class. Another class of drugs that are migraine specific, relatively new. Well, it's now 30 years on the market, but those were probably the first migraine specific medication to treat individual attacks. And the first came to the market in 1991, I believe, sumatriptan or Imitrex. And the triptan as a class has now 7 different medications. They block serotonin receptors, 1B, 1D, 1F. And lasmiditan or Orlova is one of the newest migraine medication that, unlike triptans that work through 3 different subsets of serotonin receptors, work only through the one subset, 1F. And I want to bring to your attention to this medication because this is the first medication that works through receptors that have nothing to do with the vessels. And that is one of the probably nail to the coffin of vascular theory of the migraines, that we don't have to touch the vessel to treat the migraine. And there's still a lot of controversy about this, about these theories, but this is one of the medications that can be still used in a person who have a migraine if have contraindication to everything else. The next class, this is the newest class of acute migraine medications, selective CGRP receptor antagonist. It sounds a mouthful, but we did mention this CGRP protein already several times. Remember when we were talking about the release of multiple biologically active molecules during the phase of the different phases of the migraine. So it turned out that the CGRP protein we all have, but it's released during migraine attack. And that's how the studies were designed to develop some molecules that will block this protein. And they did. And there are injectable medications that block CGRP monoclonal antibody, and there are pills that can be used for treatment of individual migraine attacks, and some of them actually being used as preventive medication. Finally, neuromodulation devices. Pills is not the only treatment for migraine, pills or injections. Neuromodulation devices such as Cephaly or transcutaneous nerve stimulator. It's a little patch that you put in the forehead, and it's deliver electric stimulation of the nerve ending that located in the forehead. Nerivio is another remote electric neuromodulation. I have a couple of pictures to show you these devices a little bit later. GammaCore, a non-invasive vagal nerve stimulator, and eNeurus, single pulse transcranial magnetic stimulator. So it's all of those non-pharmacological options to treat migraine and prevent migraine. And non-specific therapy, simple analgesic, non-steroidal anti-inflammatory medication, Tylenol, ibuprofen, naproxen, opioids. Sometimes we have no choice but go with inferior medication to treat migraine in someone who does not respond to anything else, so have contraindication to other medications. Butalbital containing products such as Fioricet or Fiorinol. Again, those are medications that used when we either have contraindication to specific medication, or they were used when we didn't have anything else. We also widely use neuroleptic or dopamine antagonists and nausea medications, especially in those people who feel nausea before a headache even started. That's why I put it here in this category as non-specific therapy. But this is a migraine-specific therapy, is pretty large group of medication. And in my clinical practice, in my teaching as well, this is a medication that are my first choice, not this part. Preventive therapy of migraine, again, this is not to kind of teach you how to treat the migraine, but just to give you an idea how many options we have. Therapeutic monoclonal antibodies against CGRP. We just mentioned about. Those are long acting, that's why they work as preventive medications. Aimovig, Ajovy, Emgality, Vyepti, all those names that you might have seen commercial on TV. Those are the newest medications that we have in the past 3 years. Botulinum toxin, the Botox, the same medications that used to kind of smooth out the forehead and treat the wrinkles. It's the same drug, but it's used in many medical conditions and has very interesting history. And we do use botulinum toxin injections to treat chronic migraine when people have more days with headache than not. Again, what's a chronic migraine is different is when a person has more than 15 headache days a month. So it's not 1 or 2, it's 15 or more, and sometimes even every day. Some of the blood pressure medication, not all of them, but the ones that work through adrenergic receptors, propranolol, metoprolol, timolol, work as preventative for the migraine. Lisinopril, candesartan, also blood pressure medicines that are shown to be effective in migraine prevention. And again, when we talk about using a blood pressure medication to treat the prevent the migraine, it has nothing to do with the blood pressure. It's effect on the different receptors and different biologically active molecules in the brain and related structures that we are targeting. Verapamil, also blood pressure medicine. A few antidepressants, particularly the older one, amitriptyline and venlafaxine. Those are the 2 classes of antidepressants that are helpful in preventing the migraine. SSRI, such as Prozac, unfortunately was not effective as preventive treatment of migraine, but it can be very helpful as a person also has depression. Anti-epileptic drugs, topiramate and valproic acid, are the 2 main medications that we use in prevention of the migraine. Medicinal herbs, such as vitamins and minerals, feverfew, butterbur, magnesium, riboflavin, and CoQ10, all being studied in clinical trials and have some effect. I like to use them when somebody is very young and never been on preventive medication, or somebody who has taken a lot of other medication and has difficulty to tolerate more heavier drugs, so they have minimal side effects. They may not be as effective as the prescription drugs that we use, but when we think about the benefit of some relief from headache and less side effects, there's a quality of life overall wins with these medications. Finally, this slide is to illustrate how many different targets are currently used in specific treatment of migraine. Interestingly, some same target now used to treat individual attacks and used as preventive. For example, medications that block receptor for CGRP protein that we mentioned many times today can be used to treat migraine attack individually with medications such as Nurtec or Ubrelvy, but it can also be used to prevent migraine, to reduce the headache frequency. And those medications are Vyepti, Ajovy, Aimovig, Emgality, and some of the molecules such as Nurtec and the newest medication just approved by FDA 2 weeks ago, they can be used to treat attack and prevent them. So this is a completely new concept in headache medicine, that now we have the same medication work on several levels of headache. Then again, this slide is not to confuse you, not to make it more complicated, but I want to just to emphasize that there are some medication works at the level of our brain cells. Lasmiditan or Rayvow, one of the new migraine medication. Most daily preventive medications, such as anticonvulsant, blood pressure medicine, they do work through the brain. There are some medications that work at the level of trigeminal nerve endings, the ones that leave the brain and distributed around the brain lining and vessels around the brain lining. Most of triptans or migraine-specific abortive medications such as Imitrex, Maxalt, Almotriptan, Elatriptan, so at least all of those medications are available at this time. lasmiditan also work at this level, so it work both inside the brain at the level of nerve ending. And botulinum toxin work here through the nerve ending. And finally, the number of medication work completely outside of the brain and outside of the nerve ending. Some of the triptans, again, and newer CGRP blocking medications such as Nurtec or Ubrelvy, monoclonal antibodies against CGRP injectables that block receptor to CGRP, and some block protein itself. Anyway, they work outside of the brain. An implication here that because they don't go inside of the brain, they do not cause sedation, they do not cause somnolence, and they have less side effects, basically. And finally, I promised you to show the picture of some of the non-drug therapies of migraine. Sorry for the typo here. Devices that are approved by FDA to treat both migraine attacks, and some of them also as preventive treatment. So here you can see a transcutaneous supraorbital nerve stimulation or cephaly device. That's like a Wonder Woman, this little patch that you applied across the forehead. There's magnetic, this battery inside of this little gizmo that attached as a little magnet. You press the button and it starts stimulating the nerve ending. This is over-the-counter device that comes in both acute treatment regimen and preventive. Unfortunately, not covered by insurance, unfortunately, very expensive. So those are basically the limitations for these devices. Remote electrical neuromodulation. Also electric stimulation, the difference that the patch will go on the shoulder. And it is connected to your cell phone, and you can increase the intensity looking at the screen of your phone. And the way it works is that it irritates or stimulates certain nerve endings that have different threshold to different electric stimuli. And this is a nerve endings that project to the same area as a trigeminal nerve ending, and that's how it feels that it can be very helpful to treat individual attacks, especially in the pregnant women, especially in those who cannot tolerate medications. It's a very, very safe way of treatment. Non-invasive vagal nerve stimulator, or gamma core, looks like a little taser, and basically that's what it is. It's discharge electric stimulation in the area of the vagal nerve that you would need to find a locate next to your carotid artery. So of course it's contraindicated if somebody has a problem with carotid arteries, but this device can be used to treat individual attacks and also used as a preventative. Again, cost and availability of this device, this is a limitation, the main limitation. And single pulse transcranial magnetic stimulation in neurons. This looks like a little device that you would apply at the back of the head. And initially it was designed as a treatment for migraine with aura. So at the onset of the aura, we know that it starts from the back of the brain. You apply the strong magnet, delivers a charge, and it's basically recharging the cells and stopping the migraine aura. It can also be used as prevention, but again, cost and availability, those are limitation. People who have some aneurysm, who have a pacemaker, who have a metal parts in electronic devices like implantable, they cannot use this electric device, but everybody else can, and it's a safe treatment. So I would like to thank you for your attention, and if you have any question, I'm happy to answer.
Thank you very much. And I'm sure that there are plenty of questions. I see Paula Crowley has a question.
Yes, thank you. Interesting talk. I was wondering if there was any known association of chronic migraines with long-term cognitive function or any other brain associated condition. So somebody has a migraines all their life, do they suffer later in life as a result of that?
So this is very, very interesting point, but as we know now, no. And that is, well, it's sometimes it's very frustrating for the people and very frightening, because how is it possible that I suffer from this condition all my life and I feel so dizzy and I might have some word finding difficulties and a confusion with a headache, and how is it possible that it does not leave a mark in the brain? It does not, because it's not a disease of the structure, it's disease of the function. And if you look at the computer, it may look perfectly fine and beautiful, but if the software is not working, it's not going to be working. So the caveat here, though, that there may be linked is cognitive dysfunction with medications that we use. The pyramid has a commonly side effects as a cognitive side effects. The good news is that if you stop this medication, and side effects going away. Another caveat and another medication that recently caught some attention is some of the antidepressants, which are amitriptyline and nortriptyline, and particularly in an age group 60 and older. Now we have to be very careful with this medication, because long-term use of those medication can be associated with cognitive dysfunction. Finally, sometimes migraine can be also as a sign of a vasculopathy. This is a rare condition, but it can be secondary to vascular disorder. And in that case, it's an underlying problem, not the migraine itself, not the pain in the head itself that may cause some cognitive symptoms. But what's reassuring that if we talk about the migraine alone, it does not cause any structural permanent damage to the brain. And no, it's not linked to any cognitive dysfunction in the long term.
Okay, and if I might just ask one more question. I was curious if you see any increase or decrease in migraine with menopause. So perhaps women that have had migraines their whole lives, does menopause help them, or vice versa? If they've never had migraines, then suddenly they do.
So that is a very, very common thing that we discuss in my clinic, because as I grew up in a family of migraineurs, my mom was told that when you have a migraine, don't worry, you could reach menopause and you're going to be fine. So now this notion that you're telling a young woman that, okay, well, you just wait when you go to menopause and then the migraine will go away. This is not the way I would go, because yes, as there are many women during when they have the period, they have headaches, migraine associated with the periods. So it's natural to assume when you no longer have a period, you no longer have those type of headache. But it doesn't happen to everybody. And it's not all about the periods. In the perimenopause, which is years, it's a process, it's a transformation of the woman's body. Many women have worsening of the headache, and many of them may get better, but I see plenty of women post-menopause that still have migraine, and in some, it can actually be the time when the migraine become worse. So that's what I tell my patient, that yes, you might heard that your headache might get better with menopause. I wouldn't count on that, because it may not be the case. And besides, you can't just live your life waiting for years and years. When, okay, well, you wait for when you turn a certain age and you're going to be fine. Not always happen.
Right.
So I don't give that advice.
Okay, thank you.
Other questions?
Somebody raised a hand, but I'm not sure what was that.
This me, Shirley. I'm
Shirley.
wondering if people are turning to marijuana to try to alleviate migraine headaches.
Well, marijuana is gaining a lot of publicity, and the problem with marijuana is that it does have more than 300 different compounds. And two of them most commonly studied, like THC and CBD, have completely different pharmacological profile and maybe associated with completely different function. So that's where the science is behind, because of the regulation of the clinical trials are very, very difficult to conduct, even though in Colorado, clinical trials are ongoing for a long time. But we did not get yet the good evidence that certain formulations are working great. I'll say that I have a lot of patients that telling me, well, I tried this marijuana and it does help me with anxiety or may help with the nausea. Okay, well, that's great. At the same time, as a medical professional who does not prescribe marijuana, I don't really have any guidelines, and I cannot guide the person how to choose the right formulation, what side effects to watch for, and how to manage those, and what's the dose. And that's a main problem. So what I tell my patient is that with the current lack of evidence for or against, I can't recommend for, but I'm not going to recommend against as well, because there is a pharmacological effect, clearly pharmacological effects that might be helpful. We just don't know how to use it safely yet. And that's that's where we at. Our knowledge is extremely limited. It's just such a vast, such a complex topics, and the plant so diverse that it's very difficult.
Thank you. But many of the marijuana clinics are specifically prescribing one form of or another of marijuana for certain illnesses. So they may be collecting testimonial stuff. I don't know.
Well, they might. I'll say though that when dispensary has clearly a financial gain, I would be very careful, and you will probably more likely to get to screen and separate and only get positive information, and you may not get an access to the negative, and that's where I'm concerned. That's why you want kind of independent observer to tell us what's safe, what's not safe, and we don't have it. That's the issue.
Thank you. Very legitimate stuff. Right.
Other questions? Well, let me just ask, and you may have alluded to this already. Is there any association between migraine and other problems such as stroke or other CNS diseases?
So there's a few association, but again, what does association mean, right? People who have migraine with aura do have a risk of stroke that is about doubled compared to those who do not have migraine with aura, or those who have migraine without aura. There are the multiple theories. Why is that? But interestingly is that usually stroke associated with migraine with aura happen in younger individuals who do not have a classic risk factors such as increased cholesterol, high blood pressure. Well, they may be smokers, but still this is a little bit different connection here. So the theories that explain why people with migraine with aura are more prone to stroke, to be specific, twice as often than people who do not. But the impact of the migraine, because when we talk about absolute risk, is not that great. So what I don't want, like if somebody have a migraine with aura and this is a catastrophe, I'm going to have a stroke. No. What's might be playing the role here is that need to be more careful with the other risk factors. Your blood pressure need to be more tightly controlled. So what's smoking is increasing the risk of stroke 9-fold, not at twice. So the migraine aura increase the risk of stroke double. the smoking alone is a 9-fold increase. So there are more important factors that are still modifiable. And again, risk is still low. What's the problem with this, however, is that when the person has a severe headache or you have a neurological dysfunction, like a weakness on one side, when you come to emergency room, at that time, very difficult to distinguish whether this is a stroke or it's a migraine aura. It's not easy. And this is one of the fear the people who have migraine with this unusual auras have, that one day it would be mistaken for migraine and it turned out to be a stroke. And certainly this is a risk, and we do see it in emergency room. And that's why in emergency room, when we encounter this situation, when in doubt, we always assume the worst, because time is brain. We treat aggressively stroke. It's minutes that count. So yeah, if you're concerned, go to emergency room. Okay, this is kind of my general talk. But again, this is the connection. Migraine with aura has a higher risk. The rest of types of migraine do not increase. Depression is more common. Anxiety is more common. Other pain conditions such as back pain, neck pain, abdominal pain, especially of unclear cause, those are the more commonly associated with migraine.
We have a question in
Yeah.
chat. Is it your opinion that CGRP dysfunction is at the root of most migraines?
Well, that at some point was the dominating theories that we found this like a holy ground, and this is CGRP is the explanation of everything. And now we just block CGRP and we're going to cure the migraine. Well, it turned out to be that it's not always the case. We still don't know whether it's why CGRP is increased in migraine attacks, and not everybody responds to CGRP blocking medications. So it may be that in some individuals with migraine, dysfunction of CGRP, again, whether this is genetically structured different, whether this is threshold to the release of the CGRP is lower, but it's not 100%. Now, when we use this monoclonal antibodies and again the small molecule CGRP in patient with a migraine, we do notice that some respond extremely well and some do not. So there are some other players here. So CGRP is not explanation of everything, but in certain individuals, probably it is. I see that there's a question, is acupuncture considered a legitimate treatment? So acupuncture is interesting way of treatment. And if we talk about legitimate, and then in medicine, we like to think about this, do we have evidence or we don't have an evidence? And we do have an evidence that acupuncture can be helpful, usually in addition to other preventive or acute treatments. But the level of evidence is not that great, meaning that the studies that we have showing us that yes, it can be helpful, they have some limitations. For example, how do we know, is this acupuncture procedure itself or its placebo effect? Placebo effect in many procedures is very, very high, up to 30, up to 60%, believe it or not. It's a very high percentage. And how can you perform the study when you don't really know whether you're treating or you're not treating the person who is getting the treatment? No, if they have a needle in their body or not. So expectation that, oh, I'm getting treatment, might have a relationship, therapeutic relationship with their physician is important. And this is frequently overlooked. And just having the procedure regularly, now thinking about it, being more aware of this condition. So all these factors may play a role. But there is one of the reviews that we use as a kind of judge whether it's legitimate or not, more favorable problem is that most of the insurance companies do not cover it, so it's expensive treatment. I do recommend it as an add-on to many of my patients, and I do think that safety and lack of side effects, and if we get a little bit of benefit, I think it's worth it. So benefit does outweigh the potential risks here. Maybe not a cure, we don't have cure, but for some people it may be helpful. Next question. It is excessive computer use associated with the migraine. Well, again, we talk about triggers here, right? When you think about excessive work on a computer, what is it entitled? Well, sitting, posture, light, which may be not physiological. It's not the same light that you go when you go outside and enjoy the nice day outside. It's a different light. Then you certainly, when you are on a computer, you're either working or even if you're reading the news, but it's still a lot of cognitive function here. When we pay attention what's going on a screen, we don't blink that frequent, so it may trigger more dry eyes. So all those factors, those are environmental triggers. If you have a low threshold to pain, might trigger more pain. But again, I like to think about this, that migraine is not computer-borne disease, it's not food-borne disease, it's not weather-borne disease. It's a combination of factors. And it's between a threshold and it triggers. And when they pile up the triggers and you reach a threshold, you're gonna have a headache. But when you think about this as a multitude of the different triggers working on the computer, well, you may reduce the intensity of the light. You might pay attention to your posture and find a way to adjust your chair in the way so your neck is not as getting as tight, and all this biomechanics and all this ergonomics of your table is important. So that's how I would answer this question. See that the comments that Dr. Lars Edwardson, who had worked for 20 years of the role of CGRP, has received the Brain Prize Award. Yes, and actually he's the one who discovered CGRP. And I think that's one of the pictures that I put as in a slide come from his work. Yes, he's a brilliant doctor, brilliant scientist who made great advances in migraine. Thanks to him, we have a lot of effective medication for many people. Not for everybody, though.
I don't see any other questions in chat or any hands raised. We do appreciate your time. Ken, go ahead.
Yes, I'd just like to thank Dr. Orlova very much for joining us this morning and sort of elucidating one of the most common and most perplexing of problems that face people. So thank you very much.
Oh, thank you so much for inviting, and sorry for some glitches with my screen, and it just
It's great. Thank you so much.
Bye-bye.
Stay well, everyone.
Feel free to reach if you have any questions.
Thank you.
Bye-bye.